Hello, wonderful staff of the Kent Northwest Kidney Center, the flagship of basically all dialysis units in the United States and probably the world. This is a special Independence Day monthly in-service, and I hope you all had a great 4th of July. Today we're going to talk about heparin, which, as you all know, is the blood thinner we use during the dialysis procedure to prevent clotting of the dialysis circuit. So why in the world do we need to know about heparin? Well, for starters, without heparin, we probably wouldn't have a job. During the dialysis procedure, blood is exposed to surfaces of varying thrombogenicity as it travels through the hemodialysis circuit. In the event of clotting of the blood circuit, approximately 200 milliliters of blood can be lost due to an inability to return it back to the patient. So heparin makes dialysis possible because it prevents clotting of the dialysis circuit. Secondly, in addition to the loss of blood, clotting within the capillary fibers of the dialyzer results in reduced solute clearance. So we don't clean the blood as well if we don't use anticoagulation. Third, heparin is a potentially dangerous medication and it needs to be properly dosed. Incorrect dosing can be fatal. And finally, heparin has potentially serious side effects, and we need to be familiar with these in order to ensure the safety of our patients. There are three objectives of today's talk. First, I want you to appreciate the role of heparin in making dialysis technically possible. Second, I want you to know indications for administering or holding heparin. Finally, I want you to understand the potential side effects of heparin, especially something called heparin-induced thrombocytopenia. Okay, let's go ahead and begin with a history lesson. The year was 1916. World War I was ongoing and Paris had just been bombed by Germany for the first time. The light switch was invented by William Newton and Morris Goldberg. Boy Scouts of America Incorporated. The German automobile company BMW was founded. The last emperor of China, Yuan Shikai, abdicated the throne. And finally, the Easter Rising occurred in Ireland. In this event, basically members of the Irish Republican Brotherhood proclaimed an Irish Republic. And the Irish Volunteers and Irish Citizen Army occupied the General Post Office and other buildings in Dublin before ultimately they were squelched by the British Army. There were important medical advances in 1916 as well. Oxycodone was also in 1916, a young aspiring physician named J. McLean entered medical school at Johns Hopkins University. McLean was born in San Francisco, and his father, who was a surgeon, actually died when he was only 4 years old. His mom remarried, and then the fire of 1906 destroyed the family home and ruined his stepfather's business. And so essentially, McLean was on his own at a young age, and without parental support, he worked as a laborer, including in the gold mines of California, before entering pre-medical studies at the University of California in 1914. He was in his second year of medical school at Hopkins in 1916 when he decided to work with the professor of pharmacology, Dr. William Henry Howell, in his laboratory investigating procoagulant preparations, that is, chemicals that make blood clot. But in his search for procoagulant molecules, he actually isolated a fat-soluble phosphatide compound from canine liver tissue that was actually an anticoagulant. And he wrote, the hepatophosphatid, on the other hand, when purified by many precipitations from alcohol at 60 degrees Celsius, had no thromboplastic, that is, coagulating effect, and in fact showed a marked power to inhibit coagulation. The anticoagulating action of this phosphatid is being studied and will be reported on later. In 1918, Howell coined the term heparin for this type of fat-soluble anticoagulant because it had been isolated from canine liver cells. And the Greek word for liver is heper, so heparin derived from the liver. Now, the discovery of heparin subsequently led to additional advances, including the invention of dialysis, which we'll talk about in a little bit. So, even though heparin had been discovered, it didn't become clinically available for another 20 years, and this complicated early attempts at dialysis. There was a physician named George Haas who performed the first tentative fractionated dialysis in humans in 1924 and 1925 using colloidal membranes. Now, he also used an anticoagulant called Heparin, which is derived from leeches to prevent blood from clotting in the dialysis tubes, because he realized, prevention of clotting is really critical to the success of the procedure. Problem is that Heparin is not an easy anticoagulant to use. It's very expensive. It usually has to be prepared fresh, so you had to get yourself a lot of leeches. There's great potential for toxicity, and it's very difficult to dose. So its dosing schedule is unstandardized. So the discovery of heparin was one necessary step that ultimately made dialysis possible as we know it today. The other was the invention of something called cellulose acetate or cellophane, which became commercially available in the 1940s. And cellophane was used to form the tubing and the dialyzer membrane early in dialysis history. Okay, now let's talk about the pharmacology of heparin. Heparin is a naturally occurring polysaccharide, basically a carbohydrate molecule, whose main function is to inhibit the coagulation of blood. As I mentioned earlier, it was discovered in 1916, but it didn't enter clinical trials until 1935. In the 1930s, several researchers started to explore heparin, and in 1935, Eric Jorps from the Karolinska Institute published his report on the molecule structure, and this made it possible for the first heparin product to be manufactured and released for intravenous use in 1936. Also, between 1933 and 1936, Cano Medical Research Laboratories, then it was part of the University of Toronto, perfected a technique for producing safe, non-toxic heparin that could be administered to patients in the form of a saline solution. By 1935, the first human trials of heparin were conducted, and by 1937, it was clear that Cano's heparin was safe, easily available, and effective as a blood anticoagulant. Heparin is produced by endothelial cells, the cells that line blood vessels, as well as immune cells called basophils and mast cells. It's usually stored within the secretory granules of mast cells and released only into blood vessels at sites of tissue injury. And these sites are prone to clotting. Also, it's been proposed that in addition to anticoagulation, heparin may also be a defense against certain invading bacteria and other foreign materials. How does heparin work? Well, it basically interferes with the clotting cascade. This is in part demonstrated in this diagram where factor Xa converts prothrombin into thrombin. Thrombin converts fibrinogen into fibrin, and that forms a fibrin clot. This is interrupted by something called antithrombin 3, which inhibits factor Xa and thrombin. And heparin binds to antithrombin and accelerates the degradation of factor Xa and thrombin. Interestingly, heparin has been described in many species: turkey, whale, dromedary camel, mouse, humans, lobster, freshwater mussel, clams, shrimps, mangrove crabs, sand dollars. The fact that it is preserved across so many species suggests that it is a very biologically important molecule. Heparin is commercially derived from porcine intestinal mucosa or bovine lung, primarily in China. China is able to produce large quantities of heparin at low cost, although our dependence on China for this essential medication has left us vulnerable to shortages as well as contamination, which we'll discuss. Heparin can be broadly classified into two different categories: unfractionated heparin and fractionated heparin. Unfractionated heparin is a mixture of anionic glycosaminoglycans of varying molecular size. So some are big, some are small. The half-life of unfractionated heparin, which is what we use at our dialysis unit, is about 90 minutes, and it has less predictable of an effect than fractionated, also called low molecular weight heparin. Now, low molecular weight heparin consists of only short chains of polysaccharides, basically less than 8,000 Daltons, and they're obtained by various methods of fractionation, basically, or depolymerization of the polymeric chain. The effects are more predictable than unfractionated heparin, and it has a much longer half-life. We don't use fractionated heparin in our dialysis unit, although some dialysis units around the world do. Okay, now let's discuss clinical features of heparin use. Heparin is typically administered as a bolus at the start of dialysis, followed by an hourly infusion, usually stopped 30 to 45 minutes before completion of the dialysis treatment, so that the patient will clot their puncture sites a little faster. It can, however, be administered as a single bolus at the start of dialysis. And this is what we currently do at the Northwest Kidney Center. And if clotting occurs, basically you need to increase the amount of bolus administered. If prolonged bleeding occurs at the end of dialysis after needle removal, the heparin dose needs to be reduced. And it's a good idea, if persistent prolonged bleeding occurs, to also consider an access evaluation, because sometimes if you have a narrowing, it increases the pressure inside of the fistula, and that can make it harder to clot. Interestingly, over time, there have been many major improvements in the biocompatibility of materials used in the dialysis circuit and also in the manufacturing process, and this has led to greater surface smoothness. So essentially, we've decreased the thrombogenicity of the tubing and the filters so that we can now get away with using a lot less heparin than we did in the old days. Now, not all dialysis patients receive heparin with dialysis. The decision to administer anticoagulation begins with an assessment of the patient's bleeding risk. So there are certain situations in which you really want to avoid heparin. So for example, if a patient has a really low platelet count, okay, well, platelets are a cell component inside the blood that, help clot, and if you don't have platelets, you're much more likely to bleed, and heparin, of course, would exacerbate that. If anyone has active bleeding, of course, from their GI tract or a surgical wound, or if they're bleeding a lot from their dialysis access, whether it's a catheter or fistula, clearly we wouldn't want to give them heparin under those circumstances. If anyone has undergone major surgery, particularly like spinal surgery or eye surgery in prior 72 hours, you'd want to hold heparin. Interestingly, the risk of bleeding beyond 72 hours of major surgery is no higher compared with standard risk patients. Anyone who has active intracranial or extradural hemorrhage, basically blood in the brain, you wouldn't want to give heparin. Anyone who's using systemic anticoagulants otherwise, they're on Coumadin or Apixaban or one of these other anticoagulants. Sometimes we give heparin, but usually we don't during the dialysis procedure. If someone is really uremic and they have a lot of fluid around their heart, we call that a pericardial effusion, which can get inflamed, it can bleed. So in that setting, we would hold heparin. And finally, if someone has a genetic predisposition towards bleeding, like a factor 7 or 8 deficiency, under those circumstances, we would not give them heparin. What about antiplatelet therapy? Should we hold heparin if someone is using aspirin or clopidogrel or one of these other antiplatelet agents? Usually the answer is no. It's not considered a major risk factor for bleeding among patients receiving dialysis. Similarly, using a combination of aspirin and clopidogrel, despite using heparin, doesn't appear to increase the risk of bleeding at the needle sites. The one exception is with dialysis grafts. The combination of uh, aspirin and Plavix plus heparin does appear to increase the risk of bleeding. For the first 60 years of its clinical use, heparin primarily was derived from cattle tissue. But with the rapid spread of bovine spongiform encephalopathy, more and more manufacturers abandoned the use of cattle for the production of heparin, instead switched to pigs. So most heparin now comes from pigs in China. Of course, this makes us very dependent on China for heparin, as we are for many other medications and products, and there are lots of downsides associated with this. So one way in which the dependence on Chinese heparin came to haunt us occurred in 2008, when in the United States alone there were at least 246 deaths and 785 serious illnesses associated with the administration of Chinese-derived heparin among United States dialysis patients. Symptoms that patients had included shortness of breath, nausea, vomiting, excessive sweating, low blood pressure, and life-threatening shock. Ultimately, the contaminant was identified as an oversulfated derivative of something called chondroitin sulfate, which is a closely related substance obtained from mammal or fish cartilage, and it's often used as a treatment for arthritis. But this oversulfated chondroitin is not a naturally occurring molecule, and it costs a fraction of true heparin, and it also mimics the in vitro properties of heparin. So essentially, this counterfeit addition to the heparin was almost certainly intentional as opposed to accidental. Turns out that raw heparin batches were found to have been cut from 2 to 60% with the counterfeit substances. And the motivation was attributed to essentially cost effectiveness, and there was a shortable that year of suitable pigs in China for heparin production. What are the side effects of heparin? Well, the most obvious one, of course, is prolonged bleeding, most often manifest in dialysis patients after the needles are pulled. Heparin can also actually increase your potassium level. So about 5 to 10% of patients receiving heparin also develop hyperkalemia, and it's thought to be as a result of heparin-induced suppression of the release of a hormone from your adrenal glands called aldosterone. So if you don't have enough aldosterone, people tend to run high potassium levels. Heparin can also increase your liver enzymes. So there's one called the serum AST, or aminotransferase levels. So that occurs in up to 80% of patients receiving heparin. Although it's not associated with liver dysfunction, it gets better once you stop the heparin. Chronic use of heparin can result in weakening the bones, called osteoporosis. Heparin can also cause anaphylaxis. It's basically an IgE-mediated allergic hypersensitivity. So people get the heparin, within minutes they develop trouble breathing and wheezing and chest pain. And finally, heparin can cause something called heparin-induced thrombocytopenia. I think this is an important thing to have heard of. There are two types of heparin-induced thrombocytopenia, so-called HIT. So type 1 is a mild, transient, sort of self-limited drop in platelet count that occurs within a couple days of exposure to unfractionated heparin, and it appears to result from non-immune, so it's not caused by your immune system, non-immune platelet aggregation, because heparin directly affects the platelets. You don't have to do anything about it. Essentially, you can continue the heparin. 10 to 20% of patients treated with unfractionated heparin are noted to have a reduction in platelet count consistent with this disorder. Mild thrombocytopenia, less than 100,000, can result from activation of platelet receptors, which leads to platelet aggregation. Again, mechanism is non-immune, early onset after initiating the heparin, and usually resolves spontaneously within 4 days, even if you continue the heparin. So it's not to be of really no clinical significance. In contrast, heparin-induced thrombocytopenia type 2 is a potentially devastating condition with which we need to be familiar. It occurs when heparin triggers the production of antibodies to a protein on the surface of platelets called PF4, and the antibodies bind to the PF4, and that complex can cause thrombosis and low platelet count. And in this case, heparin should be avoided with dialysis in the future. It occurs in 2 to 15% of patients exposed to heparin. It's much more serious and devastating than type 1. Generally occurs within the first 4 to 10 days of exposure to heparin. Late onset is much less common. And basically it activates both platelets as well as the coagulation cascade. Severe platelet reduction occurs rapidly. Generally, platelets remain above 20,000, and it can occur in patients that are just being started on heparin or in patients that have been re-exposed to heparin after an interval, like they received it in the past and they get exposed again. So what are some alternatives to heparin if heparin can't be used in a patient? Well, you all are very familiar with saline flushes. That's one way to get a patient through a dialysis treatment. Sometimes we put patients on warfarin, also known as Coumadin, which is basically an oral anticoagulant therapy. We're starting to use more direct oral anticoagulants these days, such as apixaban or ivaroxaban. These inhibit factor Xa, which again is part of the clotting cascade. There are also factor II inhibitors called dabigatran. And here's another picture of the clotting cascade, which shows where these medications are active. So vitamin K antagonists such as warfarin inhibit factor 9, 10, and 2. Direct oral anticoagulants such as rivaroxaban and apixaban inhibit factor 10A. And then the direct thrombin inhibitors such as dabigatran inhibit factor 2A. So if you inhibit the clotting cascade at any point along this cascade, you can prevent clotting. Another option for patients who can't use anticoagulants but are clotting frequently despite saline flushes is to consider the use of citric acid dialysate, or so-called citracate. Essentially, citric acid can be used as a partial or total replacement for either acetate or bicarbonate in the dialysate. And citrate basically reduces clotting by binding to calcium, and calcium is an important cofactor in the clotting cascade. So by essentially chelating the calcium, by binding to the calcium, it can prevent the clotting cascade. Citrate, for example, is used in blood transfusions. So, when we transfuse blood, the blood bank has added citrate to it, which again chelates the calcium so that the blood doesn't clot in the bag while it's waiting to be transfused. Now, the major problem is that you can lower someone's calcium by giving them citracate dialysate. And so if someone already has a low calcium, say they've had a prior, subtotal parathyroidectomy or something, you have to be careful, using something like this, but otherwise it tends to be very well tolerated. And citracate is available at some Northwest Kidney Center dialysis units. So heparin, of course, has to be dosed properly, otherwise we can, increase the risks that a patient will bleed. And this has happened certainly outside of the dialysis world. This is a picture of Dennis Quaid and his wife, and in 2007 they became proud parents of twins. And they were 12 days old when a nurse accidentally gave them a 1,000-time higher dose of heparin than was indicated for their body weight. And apparently that happened because the labeling of the adult and the infant versions of the product were similar, and so the Quaids ended up suing Baxter, and I think the hospital ultimately settled for $750,000. There was no long-term sequela, but there could have been. But it's also certainly happened a lot in the dialysis world, including at the Northwest Kidney Center when in 2012 a nurse injected 90,000 units of heparin while locking a dialysis catheter. Normally we'd inject maybe 3,000 to 4,000 units for that purpose. So she attempted to aspirate the heparin back, and then she sent the patient to the ER, which is appropriate, but then the catheter subsequently clotted and needed to be replaced, and the patient had to spend some time in the hospital. So it was a suboptimal situation. And there are several case reports throughout the literature in which dialysis patients have died from bleeding complications associated with excess heparin administration. So most often situation is someone gets a really big dose of heparin and then they have a head bleed and then they die. So you have to be very careful in dosing heparin properly. What to do with patients whose filter keeps clotting despite getting heparin? Well, you can increase the blood flow rate and the needle gauge. The faster the blood flow through the system, the less likely it is to clot. You can administer saline more frequently, say every 30 minutes instead of every hour. And finally, if they're still clotting despite large doses of heparin and frequent saline flushes, I think it's pretty reasonable to consider asking the nephrologist whether or not they may have a predisposition towards forming clots. And there are several conditions out there, including, say, lupus or people who have malignancy, who are more likely to form blood clots. Okay, time for a summary of what we've learned. In summary, hemodialysis is typically performed with heparin to prevent clotting in the blood circuit. Avoid heparin in patients with a high bleeding risk. If the filter keeps on clotting, consider increasing the heparin, using saline flushes, considering alternative forms of anticoagulation if you can't use heparin, and also consider an access evaluation. People with stenosis are more likely to clot their system. Someone has type 1 heparin associated with a modest reduction in platelet count. There's no need to change anticoagulation regimen. But if they have the type 2 hit, it's very important to avoid heparin. And finally, it's of critical importance that we dose heparin properly. Time for an assessment of how well you have retained what we've talked about. Okay, question number 1. This physician discovered heparin in 1916 as a second-year medical student. Excellent. J. McLean. Heparin is primarily produced commercially from what animal? You got it, from pigs, and you get extra credit if you said pigs in China. So what are some of the side effects of heparin? You got it. So of course, increased risk of bleeding, high potassium, elevated liver enzymes, osteoporosis, and allergic reactions ranging from anaphylaxis to heparin-induced thrombocytopenia. What are some alternatives to heparin anticoagulation? Several. You can use saline flushes. Sometimes we consider warfarin. You can put someone on one of the newer medicines, the direct oral anticoagulants that inhibit factor Xa and the factor 2 inhibitors, or consider citrate dialysate. Last question, what are contraindications to use of heparin? Excellent. So severely low platelets, active bleeding, major surgery in the prior 72 hours, blood on the brain, something called uremic pericarditis, again, fluid around the heart. Then finally, if someone has a bleeding disorder already, like a factor 7 or 8 or 9 deficiency. Okay, this concludes the Independence edition of the Kent Northwest Kidney Center in service for the month of July 2022. Thank you so much for your attention. And as I always say, thank you much more for the wonderful service that you provide our patients and for making Kent the outstanding dialysis unit that it is. This is Andy Brokenborough signing off until August 2022.